Welcome to AETCM, the Emergency Medicine channel. I am myself Dr. Vinay from General Medicine.
Please start.
I'm here presenting a case of Mr. Radhakrishnan Nair, a 68-year-old male hailing from Pathanamthitta. He was a retired government employee and is is from an upper middle class socioeconomic status. And his informant for self and wife information was reliable and adequate. And presenting complaints, the patient presented with a worsening of breathlessness since 2 weeks and right-sided chest pain since 5 days. History of presenting illness, the 68-year-old male, a known case of systemic hypertension, obstructive airway disease and carcinoma lung, diagnosed recently, now presented with complaints of worsening of breathlessness since 2 weeks. He was having breathlessness since past 10 years and was on treatment for the same with inhalational medications, and now having worsening of the breathlessness since past 2 weeks. He was having difficulty in carrying out day-to-day activities. Dyspnea was insidious in onset, gradually worsening over the past 2 weeks. And initially he was the grading of the dyspnea was around grade 3 of MMRC and later progressing to grade 4. And he was having breathlessness while lying down supine and partly relieved by sitting up and turning to one side. There was no history of trepapnea, platypnea or paroxysmal nocturnal dyspnea, no diurnal variation of dyspnea. He later started developing...
What is trepapnea and platypnea and what?
Trepapnea is when the patient was lying down to one side, the patient is having breathlessness. Okay. And platypnea is when the patient is sitting up, the patient will be having...
Where all you get all these things?
Trepapnea is seen in conditions where there is a unilateral lung disease causing pleural effusion.
Pleural effusion? Why?
On lying to one side, the fluid will be filled in the lungs, so we will be having...
So you mean to tell right side there is pleural effusion, when you lie down left side you get breathlessness, or right side?
On same side.
No, it's not like that. On the opposite side, because that side lung is not moving. Not that mobility of that part is completely restricted. And opposite side is damaged. That is one reason. Second thing is those who are having massive large cavities on one side, when they lie down on same side, sometimes the major bronchus can get obstructed. That's why we always tell that type of patient to lie down on the opposite side, like towards opposite side. So then drainage will be better. Okay. Platypnea?
Platypnea is sitting up position, the patient will be having breathlessness.
Where will you get?
In case of conditions causing any obstructive disease.
Platypnea? Orthodeoxia. Platypnea is orthodeoxia. What is that condition? Where will you get that? What is hepatopulmonary syndrome?
Causing hepatic glomerular cirrhosis, which is causing ascites and pleural.
No, you cannot tell like that. You are final year medicine PG. What is the reason for orthodeoxia in chronic liver disease? This is called as hepatopulmonary syndrome. What is the reason for that? Pleural effusion, it occurs in all patients with ascites. That is a common thing. But this is slightly different. This is due to shunting of blood in the lungs. On standing or sitting position, that shunting will increase, so that more blood will be deoxygenated. So that is the reason for that. They will be better when they are lying down. Other condition is ascites producing pleural effusion. That is same like any other pleural effusion. You should know all the differences. Orthodeoxia is entirely different from pleural effusion causing breathlessness. Okay.
And he later started to develop right-sided lower chest pain since the past 5 days. It was insidious in onset and gradually progressing, and the character of the pain was aching to sometimes stabbing kind of pain, and it was localized to the right lower chest, and the radiation of pain to the right lower back was also present. Pain gets aggravated on taking deep inspiration and while lying down to the same side, and no diurnal variation of the pain. So no history of any fever, cough with expectoration, wheeze, and no history of any recent weight loss, anorexia, or evening rise of temperature, nasal discharge or epistaxis or hemoptysis. And
Evening
no
rise of temperature is in which all conditions?
so it can be seen in infective conditions like tuberculosis and also in lymphoma.
Two important conditions. One is tuberculosis, mild fever throughout night, especially evening time. Other one is lymphoma, high degree fever, chills, rigors, night sweats. They are called as what symptoms?
B symptom.
B symptoms.
And there was no history of any palpitation, syncope, or pedal edema, and no history of abdominal pain, nausea, vomiting, belching, or altered bowel habits, or hematemesis, and no history of altered mentation, weakness of limbs, gait disturbances, or involuntary movements, or headache.
Why you are taking all these histories in a lung case? As a medicine PG, you should know about this.
To rule out any other systemic involvement.
That is a MBBS answer. You tell me why we are taking detailed history of neurological problem in a lung malignancy.
Sir, altered mentation history, if you want, if there is any underlying metastatic lesions or anything compromising the other systems, like if the patient is going into respiratory failure or
okay, respiratory failure, okay, understood. Respiratory acidosis, patient can develop altered. But as a final year medicine PG, you have to answer little better. What should be the answer? Suppose a chronic lung malignancy case come with altered behavior. One is SADH, okay. Sodium should be checked. Paraneoplastic, that is very important. There are a lot of paraneoplastic syndrome which can, like, especially related to lung malignancies, they can develop altered behavior, confusion states, transverse myelitis. So all these things are very common in patients who is having lung malignancy. It can happen in any malignancy, but it is very common in lung malignancy. So when you are taking history, you should know why we are taking that history. That is very important. Paraneoplastic syndrome can present with altered behavior, seizures, everything. Okay.
Coming to the past history, past medical history, the patient is having obstructive airway disease since the past 14 years and systemic hypertension.
He's a smoker.
He's a smoker, chronic smoker. He's a systemic hypertension since the past 4 years, and carcinoma lung was recently diagnosed in 1 year back. And he was diagnosed with a non-small cell lung cancer, adenocarcinoma, stage 4. With 6 cycles of chemotherapy was done, and no past history of any TB or contact with TB.
Okay.
Surgical history, he has a history of hemorrhoidectomy done in 2004, and a history of RTA with injury to the both shoulder, and surgery was done in 2006. The further details are not available regarding this. And recent past history, he had a 3 to 4 admissions in the past 4 months. 2 times pleural tapping was done for his pleural effusion. So coming to the drug history, he was taking a tablet cilnidipine 10 mg BD for his hypertension, and he was on SOS inhalers. And chemotherapy 6 cycles were taken. Last cycle was on the 2nd of this month. He had taken drugs like paclitaxel, carboplatin, and bevacizumab.
Okay.
And personal
history. These
history.
drugs can produce pleural effusion. Pleuritis, pleural effusion, pericarditis, pericardial effusion.
So carboplatin, there are studies showing pleurisy can be the pleuritis pain. And personal history.
How do you differentiate that type of pleural effusion from malignancy related pleural effusion?
Malignancy pleural effusion will be sudden in onset.
Massive sudden in onset. On aspiration it will be
hemorrhagic. So coming to the personal history, there will be normal bowel and bladder habits, a normal appetite, normal sleep, and he is taking mixed diet. He is a smoker, started at the age of 18 years, and he has used to smoke 7 packs of BD per day, and he smoked for around 30 years. Now he is reformed since the past 20 years. He has a 210 pack years.
Okay. 210.
Yes, sir.
210
pack years. And he is a non-alcoholic and no history of any drug abuse. And family history, there is no significant family history or no similar illness running in the family, or no history of any chronic illness like TB, malignancy running in the family.
Okay.
And allergic history, he is allergic to dust and no allergy to food.
Calculate pack year.
Number of cigarettes, number of packets of cigarettes or BD smoked per day into How many years of smoking?
Then it will be only 20 years, 20 pack years.
7 pack per day, sir.
7 pack per day.
Pack of BD per day. Sir.
Okay. 7 packs.
So, immunization history. He has a recent, in the past 2 years, he has taken COVID vaccine 2 doses. Coming to general examination, sir. Patient is conscious, cooperative, oriented to time, place, and person. He is obeying commands. Patient has a little bit slowness of speech due to underlying dyspnea. And he is moderately built and moderately nourished. Pallor was present, and grade 1 clubbing was present. No icterus, cyanosis, pedalema. A lymph node of size 0.5 centimeter was palpable on the right upper cervical and station 2, and soft to firm in consistency. Mild tenderness was present. Head to foot examination, hair was normal, dryness of skin noticed over both upper and lower limbs, minimal eczema noticed over the bilateral lower limbs, thyroid was normal, use of accessory muscles of respiration was present, no flapping tremors. And coming to vital signs, pulse rate was 112 per minute, normal sinus rhythm, normal volume and character, normal vessel wall thickening, and normal, there was no radial or radiofemoral delay, and all peripheral pulses were palpated except bilateral posterior tibial was absent and bilateral dorsalis pedis were absent.
Okay.
Blood pressure 110/70 mm mercury. It was measured in the right arm in sitting position, and respiratory rate of 24 per minute, regular abdominothoracic, and use of accessory muscles of respiration was present. And temperature was 98.6 degree Fahrenheit, and saturation was 95% with 3 liter oxygen support. And systemic examination, coming to the respiratory system examination, upper respiratory tract, the nostrils were normal, LNSA there was no flaring, and DNS to the left was noted, and no polyp or obstruction or discharge. Paranasal sinus, no erythema or swelling, no sinus tenderness. Oral cavity, oral mucosa was normal, yellowish staining of the teeth was present, gums were normal, and tonsils, fauces, and posterior pharyngeal wall was normal. Lower respiratory tract inspection, shape of the chest was normal, no drooping of shoulder, hollowing or prominence, or any kyphoscoliosis. Position of trachea appears to be central. Position of apex beat was not visible. Respiratory movements appear to be diminished over the right side compared to left side. And respiratory rate of 24 per minute, regular and abdominothoracic. Accessory muscles of respiration was use of accessory muscles of respiration was visible, and no obvious intercostal introings noted, and no visible pulsations, dilated veins, scar, sinuses, or edema of chest wall noted. Palpation, position of trachea was central, no tracheal tug or tracheal descent, and apex beat, it was palpated at left fifth intercostal space, just meet to the
tug and descent both are same.
I know, sir, it's different. Tracheal tug is usually seen in conjunction with the heartbeat.
Which condition?
It's present in case of pulmonary hypertension, any condition causing volume overload.
Since you told tracheal tug, I asked. Reserving asked, what is tracheal tug? Tracheal descent is what?
Tracheal descent is seen in chronic obstructive pulmonary disease. Deep inspiration,
trachea drops, like goes down. Tug is seen in aneurysm. Aortic arch aneurysm. Each beat that will pull down the trachea. Okay. It is a very rare situation.
Respiratory movements diminished over the right anterior and right posterior, upper and lower chest wall compared to the left side. Chest expansion, the total expansion was 3.5 centimeter, and differential expansion, right hemithorax was 1 centimeter and left hemithorax was 2.5 centimeter. And APN transverse diameter ratio is 5.7, and right hemithorax is 41 centimeter compared to left hemithorax is 39 centimeter. And vocal fremitus decreased in right mammary, right infraaxillary, and right infrascapular regions. No intercostal indrawings were present. And percussion, normal resonant note heard over the left lung fields. Stony dull note were heard over the right mammary, right axillary, infraaxillary, and right infrascapular areas. Tidal percussion was done, and no shifting dullness was present. Liver dullness could not be appreciated.
Tidal percussion, where will you get?
In case of massive pleural effusion or hemothorax, we will get tidal percussion.
Where will you get? What is this tidal percussion he has told about that? It is not required for emergency medicine. He has told about that. What is it?
Sir, we have to like percuss right.
When you get the download, you will ask the patient take a deep inspiration, then you will percuss the same area, then you will get.
If it is not moving, then it is the lesion is above diaphragm.
Above the diaphragm.
If it is moving down, then the lesion is
will be
below the diaphragm. It is not positive or negative. Tidal percussion shows shifting of dullness towards down or static. That is a correct method of telling. Okay.
And auscultation, normal vesicular breath sounds were heard over left lung fields, and bronchial breathing sounds were heard over the left infrascapular, right supraclavicular area, and right suprascapular area. Diminished breath sounds were heard over all other lung fields.
Can you tell what is this bronchial breath sound?
So bronchial breath sounds can be of three types actually.
What is this bronchial breath sound?
It is originating from a bronchus.
What is the character of that?
It can be tubular in character. Inspiratory. Same with a pause in between.
Without? With pause or without pause?
With pause.
Bronchial breath sound. Where you hear bronchial breath sound normally in your auscultatory fields?
Over the trachea.
Over the trachea you get bronchial breath sound. There is an inspiration, there is an expiration, there is a gap. Inspiration and expiration is almost equal. Whereas vesicular breath sound is inspiration is longer than expiration. The gap between inspiration and expiration is completely removed, and the end of the expiration is also removed. This is called as
vesicular.
What is the mechanism behind that? Since you're a medicine PG only, I am telling this. Otherwise, I should not tell all these things. It's a physics. Filtration and attenuation quality of your lungs. So some part of the breath sounds are filtered off. That's the end of the expiration is filtered. Some part of the respiration is attenuated. That is the middle part of your breath sound. So there is an inspiration, there is no gap, there is an expiration. That phase is lesser than the inspiration. That is a vesicular breath sound. Other one is a bronchial breath sound. Why you are hearing bronchial breath sound in consolidation?
Because the attenuation is lost. So there will be a pause in between.
What is the reason for that?
Solid.
So it's a solid. Solid is a better conductor for the sound. So whatever is produced in your trachea, same thing you are hearing in your consolidation. Where will you get absent breath sounds in consolidation?
There is an associated collapse.
If there is a collapse of the lung field, or if there is a obstruction to the major bronchus, you don't get any breath sound. Okay. Whereas in pleural effusion,
we can get a bronchial.
Fluid is a better conductor or bad conductor?
The bad conductor.
It's a bad conductor for sound. So what will happen? You get vesicular breath sounds in pleural effusion. Okay. Above the pleural effusion level,
you can get a bronchial.
What is the reason for that?
There will be associated collapse.
It's a collapsed lung field. Yes. So it's only theoretical question. Normally you don't get all these things. But you get a reduced breath sound which is vesicular in character. Yes. Whereas in pneumothorax, what is the character of breath sound?
Diminished.
Diminished but vesicular or bronchial?
Vesicular.
Vesicular breath sounds. Okay.
And crepitations are present over right and left infraaxillary and infrascapular regions. And it was fine, and it's heard in inspiratory phase. Mm-hmm. Vocal resonance decreased over the right mammary, right infraaxillary, and infrascapular regions. Mm-hmm. And no bronchophony, egophony, or whispering petrology or pleural rub was appreciated. Okay. In other system examinations, cardiovascular system, JVP was not elevated. Apex beat was felt on left intercostal, fifth intercostal space, just medial to the midclavicular line. Normal character of the apex. No palpable thrills or parasternal heave. S1, S2 was normal intensity and no murmurs. GIT, shape of the abdomen was normal.
What is the thing you are looking in the heart in this patient? Should know what are we are going to look for each system in this type of patients. Heart, what you are looking?
Any signs of fluid overload or
fluid overload?
Cardiac failure.
What you are looking? Pericarditis. So here we are looking for pericardial effusion. So you have to look for muffled heart sound, enlarged heart. Okay. In lungs, already done. CNS? Again, like that, you have to see any peripheral neuropathy, all these things. Then
In GIT,
GIT?
signs of ascites or
ascites, all these things. Okay.
So shape of the abdomen was normal. Sir. Umbilicus was normal inverted. Abdomen was soft, not tender. Minimal gaseous distension was present. And liver and spleen was not palpable. No signs of any free fluid in the abdomen. Hernial orifices were normal. Bowel sounds were
Spine?
normal.
Did you examine the spine?
Yes, sir.
Is it required? Which part of the spine should be examined?
Thoracic spine.
Which is the commonest area of metastatic lesions in the spine?
Could be thoracic.
Which thoracic segment?
T10.
These all the things they'll ask in the examination. T10. T10 is the area you have to look for. Lower thoracic segments. T10 is the commonest area you get metastatic lesions. Okay.
CNS higher mental functions were normal. Cranial nerve, first cranial nerve could not be appreciated. Other cranial nerves are obviously normal.
Okay.
And motor system, bulk was normal, tone was normal, and power was 5/5 in both
Which
upper
part of the cranial nerves, which cranial nerve is important in this patient? Which cranial nerve is important? All these things are very important because will not be able to examine the patient in as a complete examination emergency room. So you have to specifically look for some areas. Which is the commonest cranial nerve involved in lung malignancies?
11th or
11th.
10th.
What is Horner syndrome? What are the characteristic features of Horner syndrome? So eye examination is a must in this patient. So Horner syndrome is one of the common CNS involvement in lung malignancies. Okay.
Sensory system was normal. Cerebellar signs could not be assessed, and no signs of any meningeal irritation. Skull and spine was normal. Okay. Summarize the case. 68-year-old male, a known case of systemic hypertension, obstructive airway disease, and carcinoma lung, recently diagnosed. Now presented with complaint of breathlessness and chest pain. He has a significant smoking history of 210 pack years. On examination, pallor was present, grade 1 clubbing was present, and there was a use of accessory muscles of respiration. He had tachycardia, tachypnea, and was maintaining a saturation of 95% with 3-liter oxygen support. And systemic examination relieved decreased respiratory movements over the right side of the chest with the decreased vocal fremitus and decreased chest expansion of the right hemithorax. Diminished breath sounds, bronchial breathing, and basal crepitations were present, and decreased vocal resonance. Other system examination showed no significant abnormalities. My provisional diagnosis would be right side pleural effusion, probably secondary to the lung malignancy, features of hypoxia.
What is the first thing you'll do in this patient in emergency room?
You have to look for the airway patency, breathing, circulation.
So airway, there is a compromisation here.
In the airway.
Not airway, breathing, there is a compromisation. What you will do for that? Immediately what you will do?
We'll take one ABG.
We know the problem. Chest X-ray is taken. That shows pleural effusion. What is the immediate step you have to do? Oxygen started. Then tapping is first thing you have to do is tapping at least 500 ml. If you remove, patient will improve. Later you can do other things, investigation, whatever you want. But immediately we have to tap, otherwise this patient will suffer for a long time. Okay, so tap immediately, then you can do all other investigations. So did we tap the fluid or?
Actually, it was the patient was recently, one day before the patient underwent a pleural tap in the outside hospital.
Okay.
And they removed around 350 ml of fluid.
If you remove massive pleural fluid from the lungs, what will happen? Like if you remove 1 or 2 liters from re-expansion
pulmonary edema.
Okay, so how do you treat re-expansion pulmonary edema? That is a common problem which is going to occur while you are tapping. Even if you tap around 600-700 ml itself, patient can develop all these problems. That's why we only tap 300 to 500 ml. So what treatment do you give immediately if the patient? BiPAP or CPAP. Positive pressure ventilation is the first one. Previously we used to reintroduce that fluid into the lungs. The patient develops breathlessness, immediately whatever is there in the syringe, we used to push it. But nowadays we know that BiPAP machine is available everywhere. That is enough to treat that problem. Okay. What other complication this patient can develop?
Post-procedure pneumothorax scan.
Pneumothorax scan. That's why we take X-ray always after
For an-
tapping. What happened to this patient afterwards?
After the patient was actually referred from outside hospital for this. The patient was having a right upper bronchogenic carcinoma, which needed interventional pulmonology for the stenting of the right bronchus, upper bronchus. So the patient was referred for interventional pulmonology. So they were actually posting the patient for stenting.
Okay. Any anemia was there in this patient?
Yes, the patient's initial blood count revealed a hemoglobin of 10.
Okay.
And counts were the total counts were 8,000 and
Okay.
hemoglobin of 10 as a neutrophilic predominant.
Okay. So, in a patient who is having COPD, what is expected hemoglobin level? This is a lesson. In a COPD patient, what is expected hemoglobin percentage?
The patient will be having polycythemia.
Normally, we expect a polycythemia.
Polycythemia.
But if the patient develops malignancy, that is one condition where you get minimal anemia. Okay. In this patient, normally we see this type of patients, we see around 16, 17, 18. But any COPD patient, if they come with slightly lower hemoglobin percentage, then we have to think about malignancy. Okay. That you have to always look. Okay. Anything else to be added? Nothing. Okay. Thank you.